Bismillahirrahmanirrahim. Assalamu alaikum. First of all, Professor Sohail Akhtar and your team, thank you very much for giving me an opportunity to be here. And it is so nice to see some old, not by our age, but by our relationship, some colleagues, Junaid Patel and Saima and everyone and the trainees over here. Very exciting to see that people have an interest in this so-called rare disease, which is not so rare anymore. So I will share one of my case, which, as Dr. Sohail Akhtar said, is a little difficult in the previous two ones. No medical disclaimers. And the idea of presenting this case is just an interactive learning. We're not here to pull someone's leg. We're here to learn from each other. And all of us have our deficiencies, and so that is important. So this is a 48-year-old gentleman, and he is a lawyer from Bahawalpur. He initially presented to a local physician, I've been told was a rheumatologist, with acute onset pain and stiffness of small joint of hands and shoulders, difficulty in lifting weights and climbing stairs. He had no prior comorbids, he had no addictions, family history was unremarkable, and there was no documentation of physical exam findings from the physician he saw. His autoimmune profile at that time revealed mildly positive ANA. They didn't report any titers or any pattern. So we can imagine, Bahawalpur, a relatively small city as compared to Karachi and Lahore. So I was not expecting to have a detailed ANA dissection. And he was reported to have an elevated CPK. The exact level, again, मुझे नहीं मिली, लेकिन ये कि notes में लिखा हुआ था कि there was a mildly elevated CPK. So he was treated as so-called connective tissue disease. There was no further dissection that what type of connective tissue disease he had. And he's been treated with prednisolone and Plaquenil for 6 months. And I was told that this was a rheumatologist. He did fine. Apparently, he was taken off the medicines in, I think, in 6 months' time. And he did okay for almost a year, or a little more than a year. And then he presented in 2021 to a pulmonologist, again in Bahawalpur. This was my ex-trainee and now working as an assistant professor at Bahawalpur Victoria Hospital. This time his predominant complaints were respiratory, and he said he's having progressive shortness of breath and non-productive cough. A little bit more history from a pulmonologist point of view revealed that he had significant exposure to pigeons, parrots, and chickens for almost 2.5 years in garage. And he was reported to have bibasilar crackles on chest auscultation. The rest of the physical exam findings were not documented, although I called him later and I tried to explore, but he said कि कुछ भी significant नहीं था. I'm going to show you the quality of the HRCT, but it was reported to have a bilateral GGOs and some peripheral reticulation, and his spirometry showed that his forced vital capacity was 60.3%, so he's falling between, touching almost moderate restriction. So he was diagnosed as diffuse parenchymal lung disease, and my ex-fellow labeled him as probable hypersensitivity pneumonitis. He started him on prednisolone, as Dr. Sohail Akhtar said, कि हमारा जो first line treatment होता है in a non-fibrotic ILD is usually prednisolone to control the inflammatory process. He was planned to give as a thioprin, but it was not available in Bahawalpur. So this is his CT. I know this is not of a great quality, and it is, a little difficult to see for the audience. But what it shows was non-specific, some ground glass haze, and some reticulation. So let me ask a trainee over here, any trainee from Indus or anywhere else, okay, what do you think? Differential diagnosis. Do you think this is HP, straightforward case of HP, or it is something else? Yes.
Keeping in mind the raised CPK level and mildly positive ANA, we could also think of polymyositis associated ILD. The proximal patient presented with the proximal muscle weakness in the first case presentation, but later on develop, and there are high chances. So
very good. Dr. Saima's training her trainees very well, right? Excellent. Anything else? Ajay, she's a consultant. Oh, I'm sorry. Okay. Okay. All right. Anyone else? So it's a straightforward case of some sort of polymyositis, or it could be something else, or we still don't know. We need further workup. So yes, you're right. So there was what we call a flavor of autoimmune disease, right? I was not sure kinko polymyositis. Yes, there were some clues. He started initially 3 years back with muscle weakness and difficulty lifting weight. और उसका बच्चा जो था वो 1 साल का था, तो उसकी चीफ कंप्लेन जब वो मेरे पास आया तो उसने बताया कि मैं उसको फिर गोद में उठाने में मुझे प्रॉब्लम होती थी. But he revealed, when you asked him. So remember that the patients won't tell you each and everything. So you have to be a detective, and Sherlock Holmes ki tarah, you have to be looking for clues. So yes, you're absolutely right that myositis was in the differential, one of the major players, or some sort of connective tissue disease. So he developed, worsening of respiratory symptoms on steroid taper. So azathioprine was not available. He was started on steroid, did well, but when he improved, they tried to taper the steroids and tried to maintain him on 5 milligram dose, but his respiratory symptoms worsened. So prednisolone was increased again to 20 milligram, which was probably not an optimal dose, but that's what happened. He improved again and then deteriorated again on tapering of oral steroids. So finally, he was referred, I think, in April or May to my clinic. The history was almost the same as described before, and physical exam showed that there was no clubbing, there was no joint inflammation. Interestingly, his musculoskeletal and neurological exam was normal. There was no skin rash, and there were crackles on chest auscultation. His autoimmune panel revealed a strongly positive ANA 3 positive with a titer of 2,560 with a nuclear envelope pattern. And his QRA was also elevated at 31.40, which was not very high, but at least, twice the level of the normal. The ESR was only 4. The CPK was normal. Aldolase was just borderline raised. So NTCCP and the rest of the ENA profile was negative. So what do you think we should do next? क्या करना चाहिए? HRCT? Yeah, exactly. So let me see. अब यहाँ पे play. I want to play this one. ये इसमें I can show you the other images as well, just to show you in continuity that how it looked like. Can we just redo it? इसको एक दफा और चलाते हैं इसको. So what do you think? Any trainee, quick, any interpretation? Museb, what do you think? Right. So there's no definite honeycombing. There is, scattered ground glass haze, probably more in the lower lobes, but it is also in other lobes as well. And there is minimal reticulation as well. So these are the static images. As you can see, even in the upper lobes and the mid-lung zones, you can see the ground glass haze and some peripheral reticulation. So what to do next? Should we just pump up the steroids or do further workup? Yes. Anyone from the audience?
ENA profile.
ENA profile अभी करवाया था, वो नेगेटिव था. तो अब क्या करें?
Then lung biopsy.
आपने polymyositis और उसका जिक्र किया था डॉक्टर ने. तो do you think is ENA profile enough to exclude that category, or should we ask for something else?
Biopsy.
Someone said something. Myositis panel. So Dr. Saab said the myositis panel. और इसका मैंने काफी होमवर्क किया. लियाकत नेशनल में एक जमाने में होता था, AKU में अभी तक नहीं होता है. और उसके अलावा साउथ सिटी, फाइनली आई गॉट इट फ्रॉम साउथ सिटी, कि उस वक्त उनके पास किट थी और उन्होंने कहा वी कैन रन द पैनल फॉर यू. सो ही अंडरवेंट दिस मायोसाइटस पैनल, जिसमें एवरीथिंग वाज नेगेटिव एक्सेप्ट एंटी-कू एंटीबॉडी. एंटी-कू एंटीबॉडी. किसी ने एंटी-कू एंटीबॉडी का नाम सुना है? Do you know what it is, or what is the clinical significance? Yes.
Myositis is highly associated with development of lung cancer. And
Lung cancer.
have a propensity to develop.
आपका पार्शियल जवाब ठीक है, आधा गलत है, लेकिन हम आपको पास कर देते हैं, ठीक है. So I'll talk about briefly, अगर डॉक्टर सुहेल अख्तर अलाउ करेंगे. तो मायोसाइटस पैनल में एंटी-कू पॉजिटिव आया, which I'll be talking about it just in few minutes. And this time he had this rash. You can see, a picture of his leg. So it was predominantly in the lower extremities, but it was there. He was seen by a dermatologist. At the same time, he was also started on mycophenolate. Dermatologist का ख्याल था कि ये skin rash है. It is not like a dermatomyositis वाली rash नहीं है, बल्कि skin rash है. He also developed deranged LFTs. I've been asked to go a little faster. There was a 5 times rise in SGPT. So unfortunately, mycophenolate was stopped and we were unable to taper prednisolone below 15 milligrams. This is just a follow-up, to show you that for the treatment by the dermatologist, by giving some antihistamines and slight, topical steroids, he improved. There was a significant drop of forced vital capacity, and he was found to have severely reduced TLCO. So if you look at the lung trajectory over here, you can see that his FVC, as you can see, is shown by the blue bar. It was okay till 2022, and then it showed a marked, decline in the forced vital capacity. So that was very worrisome. And this time I also did a DLCO on him, and it showed it was 40% of the predicted value, which was very worrisome. So I discussed this with the rheumatologist at my institution, and we decided that we should give him rituximab because of his, now rapid progression of illness. And we still thought that we need some more testing on him, especially एक entity होती है उसको हम MDA5 कहते हैं. So he was advised to see, he went back to Bhavalpur to see a pulmonologist and neurologist. He underwent further workup. ये शायद unfortunately ना चले. This is a fluoroscopy. Oh, here you go. So you can see the movement of the diaphragm to see what's going on with the diaphragm. So his right diaphragm was more involved than the left, but he had some diaphragmatic involvement. And he has small lungs, you can see in the fluoroscopic image. And he underwent electromyography over there, which showed that he has inflammatory myopathy. The nerve conduction study was normal. And I talked to my colleagues. Actually, I put it in the Pakistan Chest Society के forum पे मैंने डाला था कि भाई आप मुझे बताएं कि NDMDA5 कहाँ पे होगा, particularly. But unfortunately, जो labs बताई गई, एक मुझे शिफा इंटरनेशनल वालों की बताई गई थी, तो वहाँ पे मैंने ये बहरहाल बेचारे का रिपीट कराया. तो again, they don't have anti-MDA5, वो जर्मनी भेजते हैं उसको. But again, their anti-Q antibody was positive. So anti-Q antibodies are autoantibodies to Q, which are directed against, a complex of 2 subunits that bind to free DNA, as shown in this picture. It plays a key role in DNA repair, and it is implicated in regulation of many cellular processes such as telomere protection, etc. Anti-Q antibody syndrome जो है, जैसे डॉक्टर साहब ने बताया it has been associated with different connective tissue diseases like lupus, systemic sclerosis, MCTD वगैरह, लेकिन कुछ और clinical conditions के साथ भी rare association describe हुई है. This is a little old paper, but it is an excellent review of inflammatory myopathies with anti-co antibodies. So you can see that the majority of the cases जो थे, they were connective tissue disease associated, but there were few cases. One case was reported with lung adenocarcinoma, and another one was with in a patient with chronic renal failure. And then there was another interesting case report which I found in my literature search, जिसमें isolated interstitial lung disease थी associated with anti-co antibodies, and the patient did not qualify for a diagnosis of underlying connective tissue disease. Thank you very much for your attention.